All right. Good evening, all. Thank you again for joining on this Wednesday evening. This is the National Fellow Online Lecture Series. As we always say, this is sponsored by the Online Fellows Education Subcommittee, the Education Committee, as well as the Fellowship Committee. It's with great pleasure that we have a speaker today, Dr. Erek Latzka, who's going to be speaking on adhesive capsulitis, also known as frozen shoulder. Before we do any of these talks, we always like to kind of remind folks that this lecture is supposed to serve as an adjunct to individual programs didactics. This program is supposed to provide fellows with direct access to educational expertise with a diverse range of AMSSM members, as well as invited guests. For the fellows, especially for the CAQ examination, this is supposed to kind of act as something to kind of be able to use for that as well. A couple of housekeeping rules. Remember to please mute your microphone and turn your videos off. If you have any questions, please put that on the chat box, and myself as the moderator will go over those questions. When you put the stuff on the chat box, preferably if you could put your name and the program that you are from, that would be very helpful. Towards the end of the talk, evaluation form will be sent out on the chat box. Please feel free to kind of fill that out, kind of give us some ways you think we could do better, or some of the things we could do differently. Without further ado, I'd like to introduce Dr. Erek Latzka. He's a sports medicine fellowship trained physiatrist. He completed his medical school at Tufts in Boston, his PM&R residency at University of Washington in Seattle, and an ACGME accredited sports medicine fellowship at Swedish Medical Center, where he developed skills in diagnostic as well as procedure-guided ultrasound skills, as well as orthobiologics. He spent 5 years as an attending physician at University of Washington, directing the ultrasound curriculum for the Sports Medicine Fellowship, and he also received the department's Teacher of the Year award in 2022. Most recently, about last summer, he moved to Massachusetts, where he works at Boston Sports and Biologics. His expertise includes PRP, MFAT, BMAC, as well as a lot of ultrasound-guided procedures. He has published in multiple talks and topics, including adhesive capsulitis, which we'll be talking about today. He currently serves as an AAPM&R Biologics Curriculum Committee member, as well as an AAPM&R Technical Expert Panel on the biologic management of osteoarthritis of the knee. Thank you very much, Dr. Latzka, for joining us today. I'll stop and you could add the slides.
Thanks for the introduction, Alfy.
My pleasure.
Okay. I'm looking forward to talking about this today. It's much easier than my last presentation where I talked about 50 different diagnoses. So I hope there'll be enough material and some questions at the end. It is one of my favorite topics, one of my favorite kind of procedures to do as well. So we'll get there. So I have no disclosures. As Alfy said, this is where I trained. In particular, I give a lot of credit to my training at both University of Washington for my just being a physiatrist, and Swedish for my ultrasound skills. Troy Henning and Adam Porcho were great mentors there. But for those that don't know what sports medicine physiatrists are compared to family medicine doctors yet, we do an internship in internal medicine or general surgery. We do 3 years in PM&R. That includes 13 months of inpatient, taking care of all sorts of patients, adult, pediatrics, traumatic brain injuries, spinal cord injuries, polytrauma. Then we do a lot of consults and outpatient with pain, sports, amputee, electrodiagnostics. And then, as Alfy said, if you're doing an ACGME sports fellowship, we're all sitting for the same test. And that's why I'm talking to you today, helping you prepare for the CAQ. So I started out in Seattle. I loved it there. I had a great commute to work, and I had a lot of great people that I trained. I would have stayed there forever, but then I had too many kids in too short a time, and my wife said, let's get back to Boston. So I was really lucky to be able to join Dr. Sussman. He had the kind of perfect practice I was looking for. I got to keep doing the things that I like to do in Seattle and expand kind of my treatment toolbox even more. Our goal today will be to review the pathophysiology, exam findings, imaging findings, and treatments that may come up for adhesive capsulitis on the CAQ. Before we dive into that, there's some anatomy that may not be as familiar to all of you, so we'll talk about a little bit of that. The rotator cuff interval is the space where the biceps tendon, the long head biceps tendon, sits between two rotator cuffs. That's why it's called the rotator cuff interval. It's the space between the two rotator cuffs, subscap and supraspinatus. In this space, the important things are the coracohumeral ligament, which forms the roof of this interval, and then the superior glenohumeral ligament, which isn't shown on this image, but it is shown over here, which forms the medial and inferior border. Both of these things help to hold the biceps tendon in place. And they also form part of the anterior capsule of the shoulder joint. They're part of the ligament complex that prevents end range or stops you at end range external rotation. We'll talk about those in more detail later. First, the background on adhesive capsulitis. It's an inflammatory fibroproliferative disease that leads to a joint contracture. It affects 3 to 5% of the population, more common in females of the age 40 to 60, more commonly occurring in the non-dominant shoulder, more common in Caucasian races, and there are 3 genes that carry up to a 6 times risk factor. And then it's also more common in sedentary workers, not your kind of laborers. There are 2 types of adhesive capsulitis, and we don't know why either occur. We don't know why primary or secondary occur, but the primary type is without an injury, essentially. So that can occur more commonly in patients with diabetes. That's the largest risk factor. Thyroid disorders, dyslipidemias, Dupuytren's contractures, autoimmune disease, and Parkinson's. Secondary adhesive capsulitis occurs due to a trauma or a fracture, a rotator cuff tear, upper extremity surgery, breast surgery, or a stroke. And the 3 stages of this disease process, I used to always say, would be over in about 1.5 to 2 years. But when you actually look at the data, there's a much larger range. It can end in as little as 11 months and go on to 45 months commonly. Some patients have even reported symptoms up to 6 years later. So these stages are broken up. The easiest way to remember it is the freezing, frozen, and thawing phases. Some will report them as immature and mature, but the freezing phase is typically painful and lasts 2 to 9 months, during which range of motion is lost. The frozen stage, the range of motion has now been lost, and pain is usually better, but still felt at end ranges of motion. The thawing phase is the gradual improvement of range of motion back to normal, and that can last the longest. So how do these patients present? Typically it's in, at least for primary causes, it's an insidious onset of shoulder pain without an injury. And when they arrive at typically the primary care office, it's within the first few months, and they have non-specific pain. They have anterior shoulder pain, maybe it radiates superiorly. It's hard to identify the exacerbating factors. And most of the time it looks like subacromial impingement or proximal biceps tendonitis. And because of that, they get treated conservatively. They're referred to physical therapy. And then the patient or the physical therapist slowly notice the loss of range of motion. And once that range of motion loss is great enough, either the patient or the physical therapist, it clicks and they say, you need to go back to your doctor because this isn't subacromial impingement. This isn't biceps tendonitis. I think you have frozen shoulder. And then they come back. Usually it's been 3 months since their symptom onset and the diagnosis is finally made. It's hard to make the diagnosis earlier than that, before the range of motion loss occurs. And then your exam really depends on when you're seeing this patient in the disease course. If you're seeing them early, then, like I said, it's going to mimic rotator cuff impingement or strain, and you'll have, or biceps tendonitis. So oftentimes you'll see positive Speeds, Jurgensen's, positive Hawkins or Neers, maybe a positive empty can, or painful empty can, but not weak. Otherwise, though, it'll be pretty normal, and range of motion hasn't been affected at this point. Later on in the freezing stage, the patient begins to have pain with both active and passive range of motion, and you'll see this on exam. The first loss of range of motion typically occurs in external rotation. The reason for this, as I alluded to earlier, is that coracohumeral ligament, which is the main limitation for end range external rotation, thickens. That's the main ligament to thicken first, and that's going to take away your external rotation early in this disease process. So if you start to see external rotation loss, that's your first clue. Other special tests are pretty nonspecific and may be difficult to perform because of the range of motion limitations. If you see the patient later during that frozen phase, now these limitations in active and passive range of motion can be pretty severe. Oftentimes flexion is less than 100 degrees, external rotation is less than 10 degrees, and internal rotation is limited, less than, they can't reach L5 with their thumb, the fifth lumbar vertebrae. Pain is still there at end ranges, but when they're immobile, they're not having pain. And when they're moving it within their limited active range of motion, they also are not having pain. So what imaging do we need during this process? I think x-rays are important because they rule out the one other thing that could cause limited range of motion passively. And that's, severe glenohumeral osteoarthritis. But usually that's not high in your differential because this range of motion loss has occurred relatively quickly. And glenohumeral osteoarthritis doesn't do that. That's usually a much slower onset. Still, it's worth having a normal x-ray just to rule that out. MR arthrograms have been used historically to make the diagnosis. The first two things that they show, capsular thickening of the axillary recess and obliteration of the subcoracoid fat triangle, are shown here. So this is the subcoracoid fat triangle in a normal patient. And this is it in a patient with adhesive capsulitis. So that joint, that capsule has contracted, and that's why you're not seeing that fat triangle anymore. We can't see the coracohumeral ligament on these images. To see that, we'll go to our next slide. And here is a normal coracohumeral ligament, and here is a thickened coracohumeral ligament. On MRI, the abnormal thickness averages about 4.1 millimeters compared to a normal 2.7. This is important to note that the exam is done in a neutral position. If you're lying in that MRI tube, you're not externally rotated. Your arm is down at your side. And so there's no tension on this coracohumeral ligament. And that's important to know because these values will be different when we look at the ultrasound findings. But what is important is that the thickness of the CHL on MR arthrography correlates with limitations in range of motion. So the thicker it is, the less range of motion patients have. Ultrasound is nice because we can do it at that first visit. We don't have to send them to physical therapy. And if we suspect this as the diagnosis, we can get an earlier jump on it. So we can look at the coracohumeral ligament, and the difference is that we do it under external rotation. So this ligament is now under some tension, which is why these values of both normal thickness and abnormal thickness tend to be a bit less. We have a normal value of 1.3 millimeters and a thickened value of 3 millimeters. Other things we can see are an increase in color Doppler signal within the rotator cuff interval, and fluid in the biceps tendon sheath is a frequent finding as well. My suspicion for that, and one of the reasons why adhesive capsulitis often mimics biceps tendonitis is because that coracohumeral ligament is so thick and it's rubbing into the biceps tendon. It's taking up more space, and that biceps tendon is going to be inflamed as well because it is just adjacent and surrounded by those ligaments. The last, possible image would be arthroscopy. And this is probably only happening if patients have failed their conservative measures and are going to surgery. But the arthroscopic findings have been documented well for the last 40 years and have shown that the synovium is the main thing that changes. There are different stages of grading that synovium in terms of its color. And earlier on in the disease, it's more red, and then it becomes less red and more pink. You can see more and more adhesions as the disease process progresses. And the other thing that they notice often is a swollen red biceps tendon compared to the normal up here. So how do we treat adhesive capsulitis? This is pretty much the gamut of treatment options that have been done for the last 30 or 40 years. Physical therapy being the mainstay, along with steroid injections. And if those didn't work previously, you would jump all the way to manipulation under anesthesia or a surgical capsular release. So let's talk about each one of those individually. The reason why physical therapy is important is because these patients don't want to move their shoulders. They are in pain when they reach those end ranges. And really what they need to do, though, is keep moving. And it's one of the reasons why sedentary workers tend to have higher rates of frozen shoulder compared to jobs where you need to use your upper extremities. Those patients are forced to keep moving their arms, and they don't develop frozen shoulder, at least not as severely. So the focus should be on stretching and range of motion. What does the evidence say about physical therapy? Well, first, we know that it's better than not doing anything. We know that if you add corticosteroid injections, that's even better. If you had to choose between just corticosteroid or PT, corticosteroid injections are more effective. But PT, the combination of both of them, is better than either alone. And if you're going to do physical therapy, it is usually more beneficial if it's done after a hydrodilation or hydrodistension as opposed to before. Steroid injections have pretty much been standard of care and supported by many randomized controlled trials and systematic reviews. We know that they reduce the fibromatosis and the vascular hyperplasia, altering the disease process and even shortening the disease course if done early enough. We know that intra-articular steroid works better than subacromial, and we know that they're more effective if they're given in the early stage of the disease. There's pretty much no argument about any of those. But if you look at the JAMA systematic review by Chalumis in 2020, they also wrote that adding arthrographic distension to the intra-articular corticosteroid appeared to be associated with greater improvements in early and late short-term pain. Now, they wrote this in their discussion, but they didn't put it in their conclusion. And this kind of leads me to one of my favorite debates, and it's why I was involved in this paper in the Purple Journal just a few months ago. We wrote it over a year ago, but it took a little while to get published. And that's hydrodilation versus corticosteroid injection in treatment for adhesive capsulitis. Now, hydrodilation, hydrodilatation, hydrodistension all mean the same thing. They all mean distending the joint with fluid. The one word that does not mean that some people mix up once in a while is hydrodissection. So that is a different procedure. That is not what we're talking about. So you can use any of the first three I mentioned, but not the latter. And my takeaway from this, and it still is my conclusion, is that corticosteroid injection plus hydrodilation will outperform corticosteroid alone. And that's supported by a plethora of studies. And what is hydrodilation and how do we do it? Well, the first thing that's debated is, what kind of image guidance should we use? Should we use landmarks, ultrasound, or fluoroscopy? Well, studies show that landmark guidance have worse efficacy for hydrodilation, so I wouldn't recommend that. And ultrasound is favored for time, cost, and lack of radiation exposure compared to fluoroscopy. As for the injection approach, you can get into the joint from various directions. You can get there posteriorly, and that's probably what most people are familiar with and most experienced with. It's definitely how I did the majority of my injections early on. But in fellowship, the anterior or the rotator cuff interval approach became my kind of go-to. It's just a very useful approach for a lot of reasons, and we can get to that later. But what studies have shown is that the rotator cuff interval approach shows faster and greater improvements in pain, range of motion, and function. And why might that be? I think it's because if you're bathing this coracohumeral ligament in the corticosteroid that you're injecting, that's going to be helpful. As opposed to if you're going in posteriorly, you're probably not getting much of that flow up through the labral anchor of the biceps tendon and then down that biceps tendon sheath into the rotator cuff interval. So to get there, you really need to access that point anteriorly. Then what about the volume? There's a lot of studies. Earlier, people thought that rupturing the capsule would be the right thing to do. That's what you're essentially doing with the with surgery when you have a capsular release. But randomized controlled trials have not backed that up. They've shown that the RCTs that do support hydrodistension tend to inject more than 20 mLs. And the ones that don't support hydrodistension inject between 9 and 20 mLs. And this is a kind of a key thing to focus on, because this fact here is, the main argument in the opposition for this paper was based on this study here by Swaroop. And I feel that I'm not sure if it's a man or woman actually, but Swaroop's paper used, I think it was 14 or 18 cc. So I don't think you can call that a true hydrodistension and use it to say that hydrodistensions don't outperform corticosteroid injections alone. The next thing we know is that capsular preservation is better than capsular rupture, but that's as long as a sufficient volume is infused. And that sufficient volume averages somewhere between 25 and 29 ml based on studies where they measure the pressure and they find at what point is this capsule rupturing. So there's a lot of little details here to, how can we make these hydrodilations work better? And the conclusion should be that it should be performed with ultrasound guidance, ideally via the rotator cuff interval, slowly injecting a total volume somewhere between 25 and 30 ml. And how do we do that? So this is the first step, finding your biceps tendon at the bicipital groove. This is the demonstration of the probe here. And if we move that probe proximally by pivoting a bit and taking this oblique angle, we can follow that biceps tendon to the rotator cuff interval, where we see the supraspinatus, the coracohumeral ligament, and the subscapularis, and also the superior glenohumeral ligament. If you want, you can go one step further and pivot your probe even more to see the coracohumeral ligament in long axis, and that's what we're seeing here. But that's not really necessary for this procedure. That's just if you want to see it in long axis. So going back to our rotator cuff interval, this is how I would recommend doing the procedure. Because the anisotropy of these three tendons, the biceps tendon, the subscap, and the supraspinatus is so important, you really want to make sure you have your trajectory lined up as well as possible. And so I recommend using a gel standoff so you can see your needle before it even enters the skin. And you're advancing it to the, basically, if you think of the biceps tendon as a clock face, if you're coming in from the left side of the screen, you're aiming for 10 o'clock. If you're coming in from the right side of the screen, you'd be aiming for 2 o'clock. And you want to avoid small adjustments to your probe, because if you wag just a little bit, you can lose the anisotropy of the biceps tendon, and then it will look just like the adjacent ligaments and tendons, and you won't know where you are. So to avoid piercing the supraspinatus down here, coming in more deep, you want to have the patient externally rotating their arm as much as they can. And you want to toe in and come in from a kind of steeper angle. So you can try not to pierce too much of the supraspinatus if you don't have to. The other thing about this is if you come in with your bevel up and your point down, that will allow you to pierce through this thick coracohumeral ligament. But once you get to the biceps tendon, rotating your needle 180 degrees so that that bevel now faces downwards as opposed to up. And so the bevel will push into the biceps tendon as opposed to pierce it. Once you're there, then you can start injecting your injectate. And this is just I tried to label things to make it a little more clear for where that ligament is. Sometimes in a still image, that's harder to see, but when you wag back and forth, those can become more apparent. So this is how I set up my tray. And the reason I don't combine these things ahead of time is because I don't know how much volume I'm going to get in there. If I only get 15 cc's, then I want to make sure I've at least gotten the anesthetic and the steroid in. So the first thing I do is just lidocaine. The second one is lidocaine and ketalog. The third is ropivacaine. And the last thing I put in is saline. And the total volume on the tray here is 40 cc's. I rarely get to 40 cc's. Like I said, 25 to 30 is usually what I'm aiming for. To confirm that the hydrodistension has worked, you can look at the joint from multiple locations, including anteriorly at the coracoid. You can look posteriorly at the glenoid. This is kind of the joint that the approach you would use if you were coming in for a posterior injection. And then you can even look superiorly and see how the supraspinatus lifts off the hyaline cartilage. After I do a hydrodistension, I'm usually doing a manipulation, pretty much always, unless the patient doesn't want to or declines it for a certain reason. These manipulations are typically osteopathic techniques. There are 3 of them: Spencer's, Gongs, or Mulligan's. The only one I perform is Spencer's, just because that's the one I was taught how to do in my fellowship. I'm not a DO by training, so Spencer's is the one I have familiarity with. But all of these techniques have been shown to provide faster and greater improvements in pain and range of motion in the 3 months after the procedure. And when you compare this manipulation with a patient that is awake and able to give you feedback and tell you when you've gone far enough, that is very different from a manipulation under anesthesia, where you require succinylcholine and IV anesthetics, anesthesia there to manage the airway, and you have risks of fracture, dislocation, rotator cuff tears, and brachial plexus palsies. So I think most patients would prefer this. The other thing you can do, some people say they have a little too much pain with this procedure, and I don't always know who that's going to be. I'd say 9 out of 10 patients with the combination of anesthetics I already mentioned do fine, and it will really put up with a lot of manipulation. But occasionally you get one that just doesn't. And I always think maybe I should have done a suprascapular nerve block additionally for those patients. But I don't usually add that to my standard procedure. Some people do it standard with all their manipulations. I don't, because most of the time it works without it. And then the last option for patients that aren't better yet is an anterior capsular release. And, this should also be, the indication for this is unclear, but I think patients should have at least failed conservative measures for 12 months. And ideally, I'm steering them away from this as much as I can, because this is a self-limited disease. And if they can get by, this will likely improve on its own without a surgery. But, some people just have a job that they need to be able to do earlier, and they can't wait for the range of motion to come back. And, you can't blame them if they need to get back to work, or they're in so much pain that, and nothing has worked. So occasionally this is the right answer. It can be done open or arthroscopic. You can also add a posterior capsular release to it, but the standard of care is the anterior capsular release. Sometimes surgeons will add bursectomies and adhesion releases as well. The risks of this are axillary nerve injury or postoperative capsulitis. So we just went over all those treatments, and that's really where you need to stop, at least in terms of studying for the CAQ. I don't think anything I'll mention past this will come up on the CAQ as a test question, but I think we should still talk about some of these other options. And that's because recently there's been a lot of research in where do orthobiologics fit into this treatment algorithm. And I say recently because I really do mean recently. The only systematic reviews and meta-analyses to be published on this topic have all been published in the last year, in 2023, and even one in 2024. 5 out of 6 of them show very good outcomes for PRP. And this, to me, when I thought about this, and people had asked me about it a year ago, I never wanted to do PRP for frozen shoulder. It didn't make sense to me. I didn't know how using PRP would alter this inflammatory process. I thought, if anything, it might make it worse. But there have been a lot of randomized control studies, and they've shown PRP compared to various conservative treatments, including corticosteroids, saline, hydrodilation, ultrasonic therapy. And if you look at these results, 93% show larger range of motion improvement for PRP compared to control. 10 out of 11 better clinical and functional outcomes compared to control. 4 out of 5 favored PRP. You keep seeing a similar pattern. And here's one of the meta-analyses by Lin showing range of motion improving at 1 month and improving even, or favoring PRP at 1 month and favoring PRP even more at 3 months. So the further out you get, then that's usually the pattern with PRP. When you compare PRP in other disease processes, whether it's tendinopathy or arthritis, within the first month, there's, PRP is going to be inferior to corticosteroid. At 3 months, maybe equal. And at 6 to 12 months, that's usually where you see superiority. So we're seeing similar outcomes in adhesive capsulitis, where PRP is favored the further away you get from the injection. The VAS scores at 1 month, no difference, just like I said. And then at 3 months and 6 months, that difference is becoming greater and greater. And use meta-analysis, same thing. The VAS scores were becoming more significantly favoring PRP at 3 months than at 1 month. But there needs to be more research. There are currently no studies looking at the combination of platelet-rich plasma and hydrodilation. So that's something I have done in one patient, a patient who could not get steroids because of a history of adverse reactions to them, basically all corticosteroids. So we were going to do a dilation, and I just spoke with her about the literature and said, this is what we see with PRP, this is what we see with dilation. Can we combine them? And so we did basically a PRP injection, and then we used the platelet poor plasma to distend her joint. That was just done a month ago. And I only have an N of 1 for that right now, but we definitely need more studies. And then what about just PRP injections without dilations if we do them early on in the disease process? There are lab and animal studies showing that it might actually, prevent the disease if done early enough. And we can see changes here in the synovial membranes where there is less edema and less, there are more normal synovial folds and synovial cells. And in the joint capsule, there's much less fibrosis of the capsule in the animals that were receiving PRP injections. So there definitely needs to be more research. In terms of outcomes from all of these treatments, some of the things, I think these are some important takeaways. We used to tell patients that symptoms would resolve without treatment by 2 years. I used to tell patients that all the time, but often they're reported beyond that. There are worse outcomes after a combination of hydrodistension and corticosteroid if the coracohumeral ligament is greater than 3 millimeters. That's on ultrasound, not on MRI. So we know that if you're at 3, or if you're at 3 or below 3, you'll have a better outcome from your hydrodistension and corticosteroid injection. If you have diabetes or thyroid disease, you're also going to have a worse prognosis and higher rate of surgical intervention for patients with diabetes. So, what I would encourage is to have a high index of suspicion when you have those patients with insidious onsets of pain that look like rotator cuff impingement or biceps tendonitis, especially if they have any of those primary risk factors. And when you send those patients to physical therapy, let your physical therapist know that, I am sending them there for rotator cuff impingement or biceps tendonitis, but I still have, if the patient starts to lose range of motion, I have I want to see this patient back early in case it's adhesive capsulitis. And so I think communication with your physical therapist is very important. And that's so you can get that intra-articular corticosteroid in there as early as possible. And if they don't have range of motion loss yet, you can just do the corticosteroid injection. That's rare to be able to do that because it's hard to make the diagnosis before the range of motion loss. I think the only ways you'll be able to do that are if the patient has already had a history of frozen shoulder, usually on the opposite side, and they come in saying, this feels exactly like the frozen shoulder I had 2 years ago, and they convince you to do a corticosteroid injection. That's one way. The other way is you do a good job on your history and you put the ultrasound on that coracohumeral ligament early, and you do your diagnostic ultrasound, and you don't see anything wrong with the biceps tendon, you don't see anything wrong with the rotator cuff, you don't see any subacromial bursitis, but you do see increased color Doppler signal around that rotator cuff interval. That could clue you in that this is an early adhesive capsulitis. Next thing, if there's loss of range of motion, you got to add hydrodistension, in my opinion, to your corticosteroid injection if you want to get the best outcome and the best improvement in range of motion quickly. Platelet-rich plasma, in my practice, is second line. I still do hydrodistension and corticosteroid first. One, because they're covered by insurance, and the patients don't have to pay out of pocket. But maybe it shouldn't be second line if you look at a lot of the studies that are coming out in the last year. And then lastly, manipulation under anesthesia and capsular releases should be a last resort. I only had access to one of the CAQ textbooks, so this comes from one of those textbooks, and it says a 68-year-old right-handed female with multiple medical problems presents to your clinic with chronic aching right shoulder pain for the past few months. She denies any previous injury, surgery, or nighttime symptoms. On exam, she's only able to forward flex her shoulder to about 80 degrees, both actively and passively. She's also noted to have limited abduction, external rotation, and internal rotation. Radiographs are normal. You start her on NSAIDs, teach her Codman's exercises to do at home, and schedule follow-up in 4 weeks. Which of the following is commonly associated with her diagnosis? This is going to be pretty easy, but again, it's the only one I had access to. Option A, morbid obesity. B, diabetes mellitus, ankylosing spondylitis, or congestive heart failure. So I think you guys would all get this by now, but it's diabetes. And we kind of harped on that already about the risk factors. I think the thing to remember about diabetes is it's not just a risk factor, it's also a poor prognostic factor. And that's all. So I'd love to just talk about this and answer any questions.
Thank you very much, Dr. Latzka. If you could, I think you just stopped sharing your screen.
I can
So,
reshare if needed.
yeah, so there are a couple of questions that we have in the chat, and I have a few questions myself. So we'll start with the questions from the chat first. The first one is to kind of, talk a little bit about what your thoughts are on local anesthetics and PRP. When you do the cyber dissections, what do you use, why you use them? And also my follow-up to that is you mentioned using a combination of ropivacaine and lidocaine as well. Why you use both of those two?
So typically, I'm using a combination of lidocaine and ropivacaine because ropivacaine is less chondrotoxic. And if I'm putting a lot of anesthetic in the joint, I don't want to put a lot of lidocaine. So I'm using my lidocaine to numb up the skin, numb up the deltoid, numb the coracohumeral ligament, numb the subacromial bursa. And as I get to the joint, I'm putting more ropivacaine in there than lidocaine. And so I'm also then leaving the room for about 15 minutes after that before not before I distend the joint, but before I do my manipulation. In terms of that patient, I mentioned doing PRP plus a distension. Now, that is one that I did a suprascapular nerve block in because I didn't want to put as much anesthetic into the joint. I put some. I think there's studies out there that show as long as you do a 1-to-1 ratio of PRP to anesthetic, clinical outcomes aren't affected. But ideally, the best PRP outcome you're going to get is with no anesthetic. So that's why I think a suprascapular nerve block can be helpful there if you're going to try to do a combination PRP plus dilation.
I've always struggled doing PRP without anesthetic, even though I know that's the right thing to do sometimes, because even with anesthetic, a few patients, maybe 5 to 7% is like, I would never do that again in my life. Even when
enemy of good is perfect, right?
Right. The other question is when you do your rotator cuff interval injections, what is your technique or method? Do you switch the needle? Do you take each needle out, or you just leave the needle in and switch syringes?
I leave the needle in and I switch syringes. I've found that if I take the needle in and out and in and out over and over again, I've had patients where then when I go to inject, I see immediately the injectate flow out. And that's probably flowing out one of my other access holes or access points. So that's why I try to leave the needle in and just change my syringe.
Another question is, and I think I have my opinion on this. Is it reasonable to repeat hydrodilation prior to capsule release? I would suspect yes, but curious to your thoughts.
I don't see why not. I have repeated it. I've never had to do it 3 times. I've had a few patients that I've had to do twice, but usually you can get them to at least through that thawing phase with 2 distensions.
And one more question before I kind of ask a couple of ones that I have. The last question is more like deciphering between acute as well as insidious shoulder pain. There was a talk that Dr. Zaremski and I moderated about 2 months ago in terms of differentiating this between this acute shoulder pain and insidious shoulder pain. Thinking about other differential diagnosis, what are your thoughts on that in terms of where adhesive capsulitis falls in those two?
So meaning, I think, let me make sure I understand the question. Acute meaning this pain started in kind of intensely suddenly, whereas insidious, whereas a gradual increase in pain. I think with adhesive capsulitis, it tends to be more of that gradual increase in pain. it's not like they never had pain and then the next day they're in 7 out of 10 pain. The pain tends to almost not be noticeable in the beginning. A lot of patients say, "Oh, I thought I felt pain and then I ignored it for a while. It went away and then it came back." And so it does tend to be much more insidious, I think, than acute. What was the second half of your question, Alfy?
And I think that's the point as well. I think, I mean, when you start thinking about acute sudden onset, you start thinking about things like Parsonage-Turner syndrome, which tends to be very different in presentation just because all of a sudden it hits you. The severity of the pain is way severe than the pathology or mechanism of injury.
Cervical
I
ridic
agree.
could do that too. Yeah.
Yeah, I think
Another one, an acute presentation of calcific tendonitis can be very painful suddenly. I had a really interesting case in the last few months of a woman who came in with insidious onset of shoulder pain that came on pretty rapidly. It came on over the course of a week or two, but by the time she saw me, she was in like 8 out of 10 pain, didn't want to move her arm, and on passive range of motion, she had no external rotation. And I thought it didn't seem to just be pain inhibited external rotation. It actually uh, seemed like there was a pretty hard endpoint. And so I thought it was just going to be a really sudden presentation of adhesive capsulitis. And when I scanned her, she actually had this huge calcific deposit in her coracohumeral ligament. It wasn't in the rotator cuff, it was in the ligament. And so it was presenting just like frozen shoulder, like in terms of that external rotation loss, but it was because of the acute presentation of calcific,
so.
whatever you want to call
I
that.
have a couple of questions. One is, like you said, when this patients present itself, usually they might have some impingement bursitis, then it becomes progressive. So let's say, for example, you first see them, you get that MRI after some conservative treatments, and it shows some shoulder impingements or bursitis. You start them on therapy, and maybe during the course of the therapy, then that's when they progress to full adhesive capsulitis.
Mhm.
You usually get a second MRI, or you just say, you know what, based on clinical manifestation, this is just adhesive capsulitis. There's no need, because in my opinion, even if you look at the coracohumeral ligaments, you're gonna find some other pathologies. I think it's likely where you're just gonna see.
I never get an
MRI.
MRI. If my clinical suspicion is for adhesive capsulitis, I can't remember the last MRI I got. In this population, if there's 40 to 60 or 40 to 70, and you get an MRI, you're going to see a partial cuff tear. You're going to see a lot of other things that are going to distract you. You'll see a labral tear, and those things aren't going to explain why they have loss of passive range of motion. So you've got to trust the history and the exam, and not just and that getting that MRI will just delay everything further. You want to get that steroid in there as soon as possible.
100% agree. Another question from the chat. What's your time frame in terms of when you do a repeat hydrodilatation?
I don't think there's from a safety standpoint, there wouldn't be a minimum. I don't think I would do it, sooner than 2 or 4 weeks. That just seems kind of crazy. But that's not based on any evidence or safety. The only thing I wouldn't do, within 2 months of each other would be a repeat steroid injection. So if I gave someone a hydrodilation plus steroid, and they came back saying, I got this much better in terms of my range of motion and I want to try to get more, can we do another one? I would do it, but I wouldn't use steroid. And that's just because I don't want to hasten their other, glenohumeral joint degeneration.
So I think this is not a fair question because we're all still trying to figure out the mechanism in which PRP works. And I agree with you, for a long time, PRP for adhesive capsulitis is almost a no-no.
Yeah.
Maybe during some of your reviews, was there any slight hypothesis or thought process? Is it more for just pain control? I mean, because we know you just work with pain, or was there any other theory in terms of the mechanism in which it helps?
Yeah, I mean, there was more theory and there was more lab studies. I was surprised to see the actual, histologic changes in the amount of scar tissue deposition in the capsule and the the actual synovial cells were different. I have not looked into it too much. I really just read that paper briefly for this talk, trying to answer that question because I thought it might come up. But I think the jury's still out, and like those have not played out in clinical or human studies, right? That's just from rats with adhesive capsulitis.
So if we have a few more questions, we still technically have about 5-7 minutes. If we don't, I could give you a few more minutes. And I just want to thank you while we wait for last few minutes, Dr. Latzka, for a wonderful presentation. I think it was very well done.
Thanks, Alfy. Nice to see some of my former fellows and colleagues in the audience.
So on that note, I just want to thank you guys all for being here tonight. Everybody have a great night, and feel free to reach out to us if you have any questions.